All right, then let's get started. So today what we're looking at there is neurophysiology, microbiology, and then some pharmacology for Gavin. But we'll start off with the phys to begin with. So neurophys starts off with movement and balance. So this isn't really that important of a slide, but it's a good opening introduction kind of idea. This is an important idea to know. So the upper motor neurons innervate lower motor neurons innervate muscles. That's kind of like what they are. These neurons, I guess, are your brain and your spinal cord. Anything else is your lower motor neurons. They communicate in these sort of manners. So lower motor neurons involved in movement. They have their cell bodies located in the spinal cord and have three input points. These are the, I guess, muscle spindles, the spinal interneurons, and descending upper motor neurons, and these allow them to engage in reflexive movements. And then the upper motor neurons control voluntary and planned movements, but they don't directly innervate muscle. They interact with the lower motor neurons to do so with the input there. And then we'll talk about a little bit more about that and how that happens, and the loops involved in a sec. But those are the kind of basics, I guess. So this is the motor cortex. So this is kind of like the somatosensory cortex. It's very similar to somatosensory cortex. It's just the motor component of it. It's also termed M1. It's a strip of cortex anterior to central gyrus. So if you remember Gavin's lecture yesterday, this is the central gyrus. This is the motor cortex, I guess, in front of it. The general idea, again, is very similar to the somatosensory cortex from last time. Imagine a person basically sitting on the brain with the legs hanging off the edge. The head, the arms are on the lateral surface, whereas the legs are on the medial surface of the brain. Generally speaking, there's a rough correlation between where things are and where things innervate. It's not perfect, but it's good enough for us. And the area involved, the amount of folds, I guess, involved is equivalent to, I guess, how much control we have over that area. So our hands have a large area. I don't know, like our calf doesn't have much of an area because you don't really do anything with it except contract it, I guess. So therefore, there's a little bit of control there and difference. Cool. So the organization descending pathways. So Gavin talked about this a little bit yesterday, specifically in terms of what the pathways are, I guess. But I think the important details are good to refresh. So the main descending pathways are lateral corticospinal tract. There are others, as Gavin said yesterday, but this is the main one. And that's this one here. This pathway decussates at the pyramids, meaning the left side of the brain will rotate the right side of the body, but critically it desiccates at the pyramids, not at the level. Whereas the spinal thalamic desiccated at the level and ascended up. This desiccates at the pyramids as well. There's also an organization involved with these, I guess, nerves, with both realistically the lateral corticospinal tract as well as the ventral horn itself. These realistically, how you can think of it, all these outer tracts, all these white matter tracts, think of it as whatever's closest to the grey matter is cervical, and then it comes out, I guess, normally. So it goes cervical, thoracic, lumbar, then sacral as you go down your body. In your ventral horns, extensors are found more dorsally, so the back side, and then your flexors are found more posteriorly. So here in this diagram, here your extensors are found at the back, your flexors at the front. And like I said earlier, it's the exact same organization for your ascending loops. Whatever is closest to the grey matter will have your cervical, and then you work backwards. So cervical's here, work backwards to your sacral, cervical's here, work backwards to your sacral, and that's your organization there. Oops. These are some, I guess, details or key points for the three tracks. Realistically, most important, second most important, least important, but this is for your brain, I guess, and it's slightly different things. But have an idea of those in your own time. I guess the protein here is the location of what they do. It's kind of important. All right, so this is an important slide to kind of think about your clinical exam, but also, I guess, what you might perceive as lesions or symptoms when you're assessing someone, perhaps. So upper motor neurons lesions are symptoms that I guess affect your brain or your spinal cord, and they have both immediate and then long-term symptoms of what's going on. Most of what we perceive as upper motor neuron lesion signs are long-term symptoms. The immediate symptoms are very similar to the lower motor neuron ones. So the flaccidity, hypertonia, areflexia are very much like the lower motor neurons, which are damage called like trauma, ischemia, or other things. And it's basically you lose innervation to that muscle. And when you lose innervation to that muscle, it causes paralysis, as you might expect, an atrophy because it's not moving anywhere, and areflexia. These are basically just because there's no connection. This is from a spinal shock kind of concept. Long-term symptoms is the loss of fine movements, but general movements will return, but also increase in spasticity, so hyperreflexion and hypertonia, as well as the Babinski sign. And these two we'll talk about in a little bit more detail in terms of why that happens with an upper motor neuron lesion, so a lesion in your brain or your spinal cord. But this differential is very, very important to make sure you get. Associated with this is also like fasciculations as well. You get upper motor neuron lesions. Okay, so why you get the upper motor neurons lesions? So hyperreflex or hypertonia, the Babinski reflex. So hyperreflexia because you have a failure of the stretch reflex. Basically, what normally happens when you have a reflexive, reaction, you have a reflex will, contract it back. But normally what happens is the antagonist muscle on the backside will also pull a little bit to reduce how strong that reaction is. When you have an upper motor neuron lesion, that's reduced because the antagonist muscle is normally controlled by the upper motor neurons. Now, back in your clinical exam days, if you ask them to clench their jaw or count to 10 or something like that, that's called the Gendrastic maneuver. That aims to decrease that ascending control, so as we can heighten the reflex by choice. But for them, they can't do that, or they just have it naturally, and it's hyperreflexic, above what we'd even do with the Gendrastic maneuver. And that causes to have an exaggerated reflex. It can also cause clonus, the rhythmic contraction of perhaps their ankle or the calf muscle in their ankle, causing their ankle to have ankle clonus. Hypertonia runs in a very similar principle, whereas there's an increased just general excitability going on, causing there to be increased tone as you move their ankle or move their knee around. The Babinski sign is a similar. So Babinski is a pathological flexion of their toes. Normal infants and really small babies, but in adults, it's abnormal. It's also called a positive planters, if you ever hear that term. This is motor neuron damage or cortical spinal damage. All right, and this is the region of the cerebral cortex. So this is, the more physiological look at the cortex rather than the specific anatomical neuroanatomy look we had yesterday. But there are a couple of areas, and there are area 4, area 6, and areas 5 and 7 that we really care about, alongside areas, the motor cortex. So these are the areas. So area 4, also known as the primary motor cortex or the M1, comprises of Brodmann's areas 1, 2, and 3, written as 3, 1, and 2 by convention, but I think that's how they were found. These basically are where volitional movements start, and they will progress through to the corticospinal tract. So this is where your motor cortex was, this is where your homunculus was, this is kind of where that all is generated. Area 6 is the pre and the supplementary motor cortex areas. So the pre or the PMA, the premotor area, is responsible for sensory guided movements, and the SMA is responsible for planning of motor actions, especially for memory and acquiring new motor sequences. These have inputs from the PPC, which we'll talk about in a second. Basically what these do is they generate complex motor plans, and these are made in area 6, and area sent to area 4, which are broken down into paths that can, be sent down the pathway. So this generates the plan, sends to area 4, which translates it basically to actual movements that we can actually do. Lesions here cause apraxia, problems with complicated movements, but simpler movements are okay. The PPC, the area is the posterior parietal cortex, is a sensory motor integration area, basically using that visual and proprioceptive information to give guidance to, the motor cortex. Area 5 gets somatosensory information, area 7 gets visual and proprioceptive information, and basically lesions there affect your body image, your perception of spatial relations, and your decision making. So basically your perception of space and where things are. Okay, so the role of the cerebellum. So the cerebellum helps refine movements, but doesn't target the lower motor neurons. These are, the roles of the cerebellum. So posture and balance, coordination, motor learning, and cognition. As we hopefully recall from yesterday, these are the 3, areas of the cerebellum. They are located with specific areas of the cerebellum, but we'll talk about these in a little bit more detail in terms of specifically what they each do and therefore lesions in each aspect have to do. These will target the contralateral motor cortex, but will end up affecting ipsilateral movements because as the cerebellum moves contralaterally to the other side of the motor cortex, this motor cortex will also innervate the contralateral side, meaning the side that's affected will end up being the same side as the cerebellum anyway, as it kind of does a double flip. These double flips will become very present in neuroanatomy. This is only really the start of this annoying concept. But basically, it goes across to the right side or the left side, depending on whether the cerebellum was or the opposite side, and the brain will send itself across the opposite side as it decusates at the pyramids. Cool. So the three components, the vestibular cerebellum. Importantly, this is at the floccular nodular lobe, and it's involved in balance, gait, and eye movements. It has these inputs, which are important, but these are symptoms. So basically, your balance is impaired, or anything to do with your balance or your vestibular system. Your eyes are linked to your balance and your vestibular connections. That's why they're affected too. Your spinal cerebellum. So this is your vermis and your intermediate hemisphere, and these control ongoing limb movements. And so they affect ataxia, dyskinesia, dysmetria, dysdiakinesia, intention tremor. So these are your uncoordinated, inaccurate movements. So whilst the vestibular cerebellum is about balance, this is about your coordination, I guess, of your movements. Decompensation of synergic multi-joint movements, fingers and nose tests, and dysmetria causing, I guess, lack of coordination. Your cerebrocerebellum is a little bit more about planning, modifying, learning movements. And these are in your lateral hemispheres, and they affect motor memory, as well as cognitive function, as well as spatial cognition. So these are the more, I guess, your planning of movements. This is your action of movements, or your coordination of movements. This is your balance. And these are important because they can definitely ask you where things are, and then, I guess, associated location. So maybe give you an infarct of this presentation, you have to work out that it's the vestibular cerebellum that's impaired, and that's at the floccular nodular lobe, for instance, something along those lines. So this is the general, I guess, idea of what can happen with cerebellum pathology. Realistically, how much of the etiology you need to care about is not much, but these are things that can cause it. These are all cancers. These are all hemorrhages of some kind. This is poisons. You can read titles. This Danish is a good way to know it's a cerebellar problem, but basically if it's a coordination problem of some kind, it's a cerebellar problem or cerebellum problem, because that's what it does. If you have an ipsilateral problem, so one-sided, think a infarct, think a tumor, think something that's located specifically in that one side. If it's bilateral, think drugs and think toxins, things that affect things systemically. Okay, so the basal ganglia. So this forms a motor loop with the cortex and the thalamus. And basically it's just control through that. It then has two roles, so shifting between mental sets and reinforcement learning. Now the important concepts here are these direct and indirect pathways, as well as the dopamine pathway, which we'll go through in a second, because this has a significant role to play with your Parkinson's disease and your Huntington's disease and your other, I guess, hypokinetic and hyperkinetic conditions. So we'll first look at the direct pathway of the basal ganglia. Now, realistically speaking, this is just something you have to look at a few times to really understand why it's going on. I have it in words here, and I'll go through it quickly in a second. We'll go through it in a second, but it's just something that's important to have a think about, to understand properly. But basically, it's a positive feedback loop and has a net facilitatory effect on the cortex. It's a net effect because there's a lot of random steps in it. But overall, if you activate the direct pathway, you'll get an increase in movement effectively. How it works is that your cortex always sends a positive, I guess, signal. This sends to the striatum, which increases its negative feedback or negative impact to the globus pallidus internus. What that does is it inhibits the inhibitory effect, therefore reducing the inhibitory effect of the globus pallidus internus on the ventrolateral nucleus pars in the thalamus, the VLO. That, therefore, is reduced in terms of the impact it has on the VLO, increasing its own positive impact on the cortex, therefore self-propagating and increasing the positive activity that it has. And that's contrasted with the indirect pathway, which has a net suppressive effect on the cortex. Very similarly, there's a positive effect on the striatum, but that increased effect on the striatum increases the inhibitory effect on the globus pallidus externus, which decreases, so there's a decrease in the globus pallidus internus effect. Therefore, there's an inhibits the normal inhibitory effect on the subthalamic nucleus, which increases the positive effect on the globus pallidus internus. That, as always, or did before, now therefore suppresses the VLO, and therefore will suppress the amount of positive signal the cortex gets, as a result being a net inhibitory or suppressive pathway. Now, how we pick those depends on dopamine. So dopamine will depend on which pathway specifically is taken, be that the direct or the indirect. If dopamine is present, the direct pathway is selected, and the indirect, the negative pathway, or the indirect pathway, sorry. This is because the direct pathways in GPI, global pallidus internus, have D1 receptors which are excited by dopamine, and thus will trigger that pathway to happen, whereas the GPE, global pallidus externus, will have D2 receptors which are inhibited, and thus will inhibit this pathway as they move through. Dopamine comes from the pars reticulum stancia nigra compacta. This is an important location of the brain, and is one that I would commit to memory because it's literally the location you look for things such as Parkinson's disease, where you see decreased pigmentation. But these result in hypo and hyperkinetic disorders. So Parkinson's disease and Huntington's disease is a main classical example. So Parkinson's disease is from overactive to indirect, from reduction in dopamine, causing your akinesia and your bradykinesia. Huntington's disease is the opposite. So it's under captivity of the indirect pathway, leading to dyskinesia and hypotonia. So Parkinson's disease, it's a progressive neurodegenerative disorder, and it results in a resting tremor, rigidity, bradykinesia, and postural instability. Your classic TRAP acronym, so your tremor, your rigidity, your akinesia/bradykinesia, and your postural instability. TRAP is a good way to kind of remember that. Etiology-wise, it's generally thought to be idiopathic. You can have drugs that cause Parkinsonism with dopamine antagonists, which Gavin will talk about later, but they effectively cause the same symptoms of Parkinsonism. It is not Parkinson's disease itself. Pathophysiology-wise, it's due to a degeneration of the substantia nigra pars compacta, the location that produces the dopamine. As this amount of dopamine is reduced, and you have to be quite significant to get any symptoms, then you'll have an increase or lack of inhibition of the indirect pathway, causing there to be increased tonic inhibition, which results in the akinesia and the bradykinesia that we see. Lewy bodies are seen in autopsy. This is kind of buzzwordy, so it's just kind of important. These can't be found before they pass away, so they're only seen in autopsy. Again, this is your classic symptom, so your TRAP really, so I've organized it in a weird way, but tremor, rigidity, kinesia or akinesia, and postural instability. There are other signs that are important. So your masked faces, your shuffling gait. They have difficulties turning around. They have difficulty starting and stopping actions, which is why they have a shuffling gait. They have a reduced, mood, so depression, anxiety, as well as other factors, such as constipation. But things are basically slowed, and you can use that to kind of give you an idea of what symptoms might be. This pharmacology will be given a little more detail specifically in terms of medications in the pharmacology section of this talk. But generally speaking, it requires a multidisciplinary team with the Parkinson's nurse, physiotherapist, et cetera. Your allied health is important, and your pharmacological aspect includes your levodopa and your carbidopa. And why we use two drugs will be talked about in a second. There's also weird and wonderful techniques called deep brain stimulation. I'm pretty sure this works well, but you are putting something into someone's brain, which is risky in its own right. But when have a look at some videos online, they do seem to work quite well. Huntington's disease, however, is the complete opposite. So this is an inherited autosomal dominant neurodegenerative disease with 100% penetrance, meaning that every single parent who has Huntington's disease will be guaranteed to pass it on to their children. This is atrophy of the GABAergic neurons in the striatum, causing dopamine hyperactivity. Basically speaking, there's too much dopamine now, reducing the activity of the indirect pathway. They have a thing called chorea, which translates to a mad dance, but basically just means an irregular, unpredictable, purposeless, rapid movements. They just act what we don't expect them to act, or in extravagant ways. They have impaired voluntary movements and monoclonic jerks. They also have hypotonia, cognitive deficits, and psychiatric symptoms. There's not really much treatment for this, and not really much management. So realistically speaking, if you decide to genetic test them, is actually a debate in itself, because you can't really do anything for them, or can't do much for them as of right now. Okay, so maintaining balance and talking about balance in general. So to maintain balance, there's a couple of multiple sources. So proprioceptive, vestibular inputs, and visual inputs. So proprioceptive inputs basically looking at the mechanical changes in the body, vestibular inputs looking at the head movements, and visual inputs looking at the optic and visual inputs, basically, how we see. These are interpreted as vestibular, nucleus, and cerebellum, and if they fail, it causes dizziness or something is incongruent. The vestibular system is in your ears and is also known as the vestibular labyrinth and provides balance and information that aids postural reflexes and guides eye movements. This allows you to have the VOR, the vestibular ocular reflex, and basically allows you to move your eyes to compensate for head images as you move your head. So if you move your head, your vision doesn't go blurry all of a sudden. That's because of this reflex. The vestibular system is also composed of two parts, the semicircular canals and the otolith organs. These are for rotational and linear acceleration respectively, and we'll talk about those in a second. Cool. So the semicircular canals have two pairs of three sets of canals on each side of the head, and they're orthogonal or 90 degrees apart. This is a key term. The fact that the 90 degrees is very important. Because it allows the X, Y, and Z axis direction, I guess. But it's just a thing you need to know, that they're in all the three axes. They function as a push-pull system, meaning that when you tilt your head one way, one side will be pulled, one side will be pushed, i.e. one side is activated and one side is inhibited, giving your, I guess, brain an understanding of where things are going on, where your head is in place. How they work is basically they have a detection point, some hairs, and some fluid. And then what happens is when you move your head, things will be adjusted or pushed, and that will cause your hairs to tilt one direction. That will either be an activation or a suppression. But the ampulla is what's detecting things as they move through. And the cupula, which is the gel, will exaggerate those movements, and that's important so you actually see what's going on. So they rely on that crista ampullus and the endolymph to push things together. So when they basically push on the cupula, it causes the kinocilia within it to kind of push against, and that will cause depolarization, and the opposite side, hyperpolarization, with the push-pull effect. Now, these hair cells detect acceleration, so a sudden change in, I guess, your speed of movement. And as such, if you kind of stay at the same velocity, but you're still spinning, it will just return to midline and become normal. Now, that is when you get dizzy, when your visual input obviously tells you that you're not standing still. And I guess this is the point of spotting, to try and reduce that congruence, which is what dancers apparently do. When your rotation does stop, your inertia will therefore force the fluid to go further, causing you to feel like you have a counter rotation of fluid. A counter rotation because your fluid goes the other side. That's kind of the logic there. But the important aspects of this is the fact that there are a paired set of three canals. They're orthogonal. They work on a push-pull system because these hairs, as you kind of tilt one way, you push. You tilt the other way, the other side will be pulled. If that makes sense. The otolith organisms or organs run very, very similarly. So they detect linear accelerations relative to gravity. And they're composed of the utricle and the saccule for horizontal and vertical movements, respectively. The macula is a sensory structure for the otolith organ. So it's the same thing as the cupula and the ampulla before, but basically they just detect backwards and forwards. These have a gel or a layer of otoconia at the top, basically making it a bit heavier to better detect that change. Cool. How they work is very, very similar to the ones above. So they have a tallest hair, and this is the stereocilia, and they have springs between them. As they bend towards the kinocilium, kinocilium, sorry, is the tallest. As they bend towards that, it will cause activation and influx of potassium. As they go against it, it will cause hyperpolarization. Perpendicular movements will do nothing. As a result, this will detect if you're moving forwards or backwards and things like that. It's mentioned that this is a feedback system rather than a feed-forward system, and as such, you can't really anticipate the instability. You just have to react to it. But it doesn't really make sense for it to be anticipatory anyway, if I'm honest. And this is not the most important slide ever, but this is the vestibular inputs and where they kind of go. So these will all sign to the vestibular component of the vestibular coccygeal nerve at Scarpa's ganglion. These are located in the rostral medulla, and these three inputs, and this is the output, which is just the balance aspect. So inputs lateral nuclei from the otolith organisms, the semicircular canals, and then for visual sort of inputs. As we said before, the vestibular ocular reflex is what allows you to keep your head or your eyes fixated on an object whilst your head is moving. This is also what happens with the Dole's test, whereby it basically means basically tells us that you don't really need to have visual input or conscious input to have this happen. It's an intrinsic reflex with your eyes connected to your otolith organs in your vestibular, system. But as it works, as you excite the right of you turn, it will excite the left muscles to contract and or reflexically adjust for that change. Clinically speaking, it's not too relevant, realistically speaking, but there's a thing called caloric testing, where we tilt people's heads to try and work out brainstem function. There's these rules in terms of what you're looking for, and you're looking for nystagmus. There's called a fast flicker and a slow flicker. So your eyes will literally flicker one way and go backwards slower. This is described in that picture here if you're really interested, but this I don't think will get assessed, if I'm going to be honest. This can cause something called giddiness and dizziness. So dizziness can form from a number of causes, these being vertigo, presyncope, disequilibrium, and lightheadedness. Again, these aren't the most important things, but vertigo is important to fully understand. Basically, it's an idea the world is spinning in space. So the world is literally spinning as you see it. And then there's a strong indicator of vestibular disease. But the other three terms, presyncope is your perception of being about to faint. So those of you who fainted before may have felt that. These are the three disorders that are associated with vestibular problems. They aren't super important, but they're called Meniere's, benign proximal positional vertigo. This is very common and is the most common cause of vertigo, but it's not that important. And vestibular neuronitis. And these are conditions that exist, but I wouldn't expect to be assessed. All right, speech. So this was talked about a little bit yesterday with the Broca's and Wernicke's areas, but there's a little bit a different angle. This isn't really too important, but this is just basically what speech and language are. But language and how it's processed is kind of important for why we have the three types of aphasia that are kind of important for a second year. So inputs include both written words and speech. And I guess this is the acoustic or visual information is processed. From there, they have to be processed towards a processing area, and then they have to be outputted, basically both text and speech, either you're writing or you're speaking. And as a result, the three pathologies I really care about are problems with these three. So your input is Wernicke's aphasia, where you can perfectly output fine, but you can't input the information. Broca's aphasia is when you can't output the information, but you can probably input it fine. You just can't really speak in a coherent manner. And then the third one is a conduction aphasia, where there's a problem in the middle stage of transferring information across, where the problem is repeating words. This is a thing, I wouldn't put this to memory, but it's a thing that was present, realistically. The key thing is that most people have left lateralization for language, like Gavin said yesterday. So we'll move on from here. All right, so aphasias are the inability or the impaired ability to understand or produce speech. They have symptoms, basically with word and speech. There are three main types. So Broca's aphasia, otherwise known as expressive or non-fluent aphasia, which might be a bit of a term if you struggle to understand what Broca's aphasia is or remember what it is. Wernicke's aphasia is receptive or fluent aphasia. They can talk fine, but they can't really understand properly. But conduction aphasia is also the failure to repeat words. And we'll talk about this in a little bit more detail into how these happen in a second. So Broca's aphasia. So this is non-fluent aphasia. They have effortful speech. They have trouble finding the words to talk, or their talking is just more difficult. They make sense, but it's hard for them to come up with the words to flow. Basically, they know what they want to say, but they just can't say it. is a problem with the language production. Importantly, like I said earlier or yesterday, the Broca's area is this location, the third frontal convolution of the inferior frontal gyrus, there basically, and it can be a problem with MCA strokes. But importantly for Broca's, they know what they want to say, they just can't say it. Wernicke's aphasia, on the other hand, is a fluent aphasia. They have a problem with language comprehension. They have word salad, they have errors in word use. And this is located in the posterior region of the left superior temporal sulcus, or the temporal parietal region, sometimes also known. And this can also be affected by an MCA stroke. And conduction aphasia is the least, I guess, important one, but they have a problem with repeating recently heard sounds, or repeating words. They have fine fluent speech and good comprehension, they just can't repeat words properly. And this is a result from the damage to the arcuate fasciculus, which is the area connecting Broca's to Wernicke's together. I would recommend looking at some videos of these aphasias, because that helps understanding and helps work out what these things are a little bit better. The Wernicke-Gershwin model is, I guess, a way of interpreting how things we hear and will then for speak is processed. So the reading and speaking is basically the same, but in terms of repetition of words, the speech is heard by ear and sent to the auditory cortex. These are understood in the Wernicke's area and then sent to Broca's area via the arcuate fasciculus. These then sent to the motor cortex to then produce the sounds through your lips, tongues, larynx, whatever. The same kind of idea is done with your reading and writing. So this is, you're seeing your visual cortex, and then it's processed into Wernicke's area, and the rest is the same. So it's the same model and the same thing, basically saying between hearing and speaking, or hearing and reading, it's just different processes. Okay, so your global and your anomic and other aphasias, these are less important, and they're described in this little drawing here, or table here, but this is a quick thing. Global aphasia is a complete inability to speak or understand language. Your small aphasia is a small damaged temporal lobe, and there's a severe word finding difficulty. And then your other aphasia is just specifically, is the speech fluent or not? Is the comprehension important or not? Or is the repetition of words important, impaired or not? These aren't really that important, and they weren't really assessed for us, nor were they expected to be assessed for us, but they're there for completion's sake. And this is a table for people who like to look at tables or graphs. In terms of damage to other parts of the brain, they can also affect different things. So right hemisphere damage may cause a voice to have a flat quality or robotic quality, with words that are words are well formed. They just sound, I think, monotone. Insula is responsible for language processing and may lead to a Broca's aphasia, and your planum temporale may cause to have, I guess, severe positive symptoms, meaning hallucinations and things like that. But these are less important to think about. Brain splitting is a thing, I guess. Basically, what we're looking at here is when the brain is split medically, because none of them really ever happen by itself. But what we notice is there's a miscommunication or discommunication between the right and the left-hand side of the brain. So when looking at stereognosis, the left hemisphere can process what's in the right hand without visual assistance, while the right hand objects in the left hand can only be described with an indirect description, i.e. they can't specifically tell what it is, they can just say the vagueness of it. And similarly with visual information, the left hemisphere responds to written commands, the right hemisphere responds to non-verbal stimuli. Effectively, to put it simply, the left hemisphere can tell what it has seen, the right hemisphere can only show it, instead of being able to say as well. But that's with the related to dominance as well. Okay, so sleep isn't as important of a section. It's very common sense. If you have bad sleep, you have bad effects, but we'll talk about it quickly. So this is the definition of sleep. You'll get it again in third year, and it's a bit pointless, but this is what sleep is. This is the point of sleep. It's to get conservation of energy, and et cetera, et cetera. Normally people sleep 7 to 8 hours a day, but I'm sure a lot of this is fairly common sense to most people. The consequences are exactly what you would expect. So neurocognitive impairment, but also more severe ones, just obesity, insulin resistance, high blood pressure, stroke, and things like that. impaired immunity, and increased mortality. In some respects, you can just think of what things are happening bad. No sleep is never a good thing, is basically what you can think of there. Sleep can be measured in a couple of ways, and this is a little bit more important. So they can have objective measures and subjective measures. So the objective measures are your polysomnographies and your actigraphies, and your subjective are your sleep diaries or your sleep quizzes and assessment scores, your Epworth sleepiness scale, for instance. Your polysomnographies are your gold standard, but they're also kind of annoying due to go into a lab to sleep. But some of these can be done at home, and that's a bit better. Sleep is measured in epochs, so 30-second stages, and basically your sleep is staged by that stuff. And your sleep will move through a bunch of stages. So each cycle will last around 90 to 120 minutes and repeated 4 to 5 times a night. REM is quite active and desynchronized and paradoxical, and REM is quiet, synchronized with delta or slow wave sleep. So your stage 1 is your first 3 stages are NREM, and your last stage is a REM stage. There's a bunch of criteria, but just know it goes through those 4 stages and it goes through. I think maybe important one, stage 2, your K complexes, stage 3, your delta waves, and stage REM is where your dreaming occurs, which might be something you can think about and buzzword. It also has impacts on breathing and cardiovascular responses, but those are there for your reading in the future. This is a diagram of your sleep cycle. This is one cycle. It will repeat a couple times after this. But as you can see, it kind of moves through. You don't really understand like what's a K wave or whatever. It just is a thing that's present. In terms of sleep regulation, there's 2 processes, the homeostatic and the circadian. The homeostatic process is when you wake up longer. If you stay awake longer, the more likely you're going to fall asleep because of a buildup of molecules in your body. The circadian rhythm, on the other hand, is by control of the light-dark cycle. It's controlled by the suprachiasmatic nuclei of the hypothalamus, connected to the retina, the pineal gland, and suprachiasmatic nuclei. Overnight, your melatonin rises, your body temperature falls, and I guess that it coincides with a fall in alertness and an increase in reaction times. And this is basically your the surroundings of your body telling you to become sleepier. Basically makes it lowest at 4 to 6 a.m. This is a problem for night shift workers, I guess, and this kind of fights their normal circadian rhythm to sleep. In terms of effects of sleep disorders, they are exactly what you do expect them to be. So medical conditions, lifestyle factors, and sleep disorders. And the sleep disorders themselves can be classified into a couple of groups. So sleep-related breathing disorders, sleep-related movement disorders, and then some other things that are related to sleep but aren't really categorized. So the most important one of these is OSA, obstructive sleep apnea. This is very common and is becoming more and more common with, I guess, increasing risk factors. So your most important risk factors are there in bold, but they're all fairly, make sense, especially with the pathophys that we'll talk about in a second. This is diagnosed formally in a polysomnography with apnea-hypopnea indexes. This is kind of interesting, I guess, but it's not something that you can definitely have to commit to memory, but you could if you wanted to. Clinical features are snoring and witness apnea, so their partner noticing that they are struggling to breathe at night, and fragmented sleep, as well as a feeling of waking up tired or waking up fatigued. And we talk about why that might be. So OSA occurs because there's basically obstruction in their airways because there's a loss of that positive reflex allowing them to breathe. Their airways will close instead of being open. And it doesn't affect them when they're awake. And the reason they wake up during their sleep causing apnea phases is because your normal awake phase is compensatory tension in the airways, keeping your airways open. When you sleep, that relaxes and therefore it compresses. And that's what the problem is going on here. And then you will wake up, fall asleep, wake up, fall asleep, wake up, fall asleep, causing your hypersomnolence as you're not really sleeping, you're just constantly choking. This causes cardiovascular sequelae, most importantly, or most clinically relevant, I guess, is systemic hypertension, but it can also increase your risk of a whole bunch of other things, primarily or partly because of your hypertension. You also has neurological sequelae, i.e. you're waking hypersomnolescence. you can't sleep properly, and therefore you have decreased attention, which increases your risk of accidents, either that be motor vehicle or workplace, as well as just a general reduced quality of life, which is pretty bad to begin with. Management occurs in 3 stages, so your behavioral, your medical, and your surgical. Yeah, so behavioral wise, losing weight, avoiding supine sleep, and avoiding as sedatives that will cause your tonic activity of your throat muscles will aid in preventing this from occurring if it's a minor problem. Weight loss will decrease the kind of weight that's put onto your throat or your trachea and things like that, or your pharynx, allowing you to sleep better, or at least breathe better. If that fails, what we can do is you can give positive airway pressure, or CPAP, so continuous positive airway pressure. Basically what it does is just blows air down your throat and tries to open it up. It's not overly comfortable, but apparently patients really like it, or some patients really like it if they are compliant with it, because it does alleviate their symptoms and does make them have a good night's sleep. It just gets them getting used to. In terms of devices, other devices, you can have oral appliances, expiratory resistance valve, and hypoglossal nerve stimulation suction devices, but they aren't as high yield, I guess. Oral appliances basically, it's like almost braces, I guess, or your Invisalign sort of thing, and they just put in your mouth to open it up. Expiratory resistance valves make it easier to breathe in and out, creating some more pressure. And then the other ones are very similar in terms of what they do. If it's really, really bad, you can go into surgical methods with reconstruction of the upper airways, as well as uvulopharyngoplasty, which is basically just remove the uvula and try and open up the airways even further. In terms of central sleep apnea, there are 2 types: hypopneic, hypocapnic, and hypocapnic. Hypocapnic is when they have hypoventilation disorders, i.e. they have high CO2 because they don't breathe. And this is partially, or one of the causes for this is obesity hyperventilation syndrome, where the obesity is associated with alveolar hypoventilation purely because I think they just can't suck the air in, and then they don't breathe enough. Hypocapnic is when you have Chine-Stokes deprivation from heart failure, and it's a waxing waning of ventilation. These aren't critically important conditions, but they are causes of central sleep apnea and are things that affect. Sleep-related movement disorders include periodic limb movement disorder, restless leg syndrome, and parasomnias. Periodic limb movement disorder is characterized by periods of repetitive limb movements in your legs. Restless leg syndrome is a side effect, I guess, interestingly, of iron deficiency, pregnancy, and kidney failure. So if you see it with iron deficiency, that might be something interesting. And parasomnia is an undesirable physical event or experience that occurs as one is going to sleep. And it's because of CNS activation. All these 3 conditions, again, probably aren't the most high yield of conditions, but they exist and are therefore relevant to someone. Disorders that causing sleep disruption include insomnia, narcolepsy, and circadian rhythm disorders. Insomnia is defined as difficulty initiating and maintaining sleep for more than 1 month despite adequate opportunity. Narcolepsy is sort of sleep-wake regulation with sudden intrusion to sleep. And circadian rhythm disorders include delayed sleep phase syndrome, whereas people go to bed late and wake up early or late. Advanced sleep phase syndrome, where people go to bed early and wake up early. And then those people who work in shift workers and jet lag is also a sleep disorder or disruption. But now we'll move on to neuropharmacology. I'll stop sharing.
Cool. All right. So I'll be doing, oh, wait, let me share first. How's that?
All good.
All right. So we'll cover neuropharm basically condition by condition, and each of the drugs and the main treatments that they use. Kevin's touched on some of them, but we'll go into a little bit more detail about how the drugs and all are working. So we'll start off with seizures and epilepsy to begin with. So what is a seizure? A seizure is basically just abnormal or excessive neuronal stimulation in the brain. So whether they're firing when they're not meant to, or there's too many neurons firing, that's what's happening when you get a seizure, and that's what's going to cause your symptoms. So your like jerky movements in your body and all those kind of motor symptoms that we typically associate with seizures. Some of the other things that we need to be aware of when looking at seizures are whether we have a preceding aura, so sensory motor, we can have smells, we can have certain like visions, or we can have movements, and then the post-ictal, what's happening after it. So post-ictal amnesia, confusion. We don't remember what happened to us before. There's a whole bunch of different etiologies of seizures, but it's pretty hard to know the exact mechanisms of them and how they're associated. But the main one I think you probably need to know are the metabolic issues, so hypoglycemia, hyponatremia, and hypocalcemia, alcohol withdrawal, and brain pathology. So whether it's bleeding, tumors, or subarachnoid aneurysms, so dilations of the vessels. How do we diagnose it? We just use our clinical history and exam, but we can also use like brain CTs, blood tests, and urine drug screens to check like alcohol and things like that, drugs. And so that's different to epilepsy, which is characterized by either 2 or more unprovoked seizures. So seizures and epilepsy are 2 different things. It's important not to confuse them. And again, the etiologies are kind of similar, but they're mainly idiopathic. We don't know the exact mechanism going on behind epilepsy, but we can make some sort of like guesses at what it might be. It might be similar things causing things in seizure. It might be physical injuries or other pathologies which are causing fibrosis of brain tissue. Cool. So how do we diagnose it? Again, we're using clinical diagnosis, but we also need to be using EEGs to identify certain epileptiform ways, which would help us diagnose epilepsy. But it's really hard to do this because you need to be using that EEG on someone while they're in the middle of a seizure. And sometimes it might even just be normal. And so that doesn't rule out epilepsy. So not the best thing. So you have to be using your history and exam as well to be sure. In order to treat it, how are we going to treat it? A lot of people go on certain prophylactic medications, which are called epileptics or anticonvulsants. Sometimes if that's not working, we can use surgery. And a lot of people also use ketogenic diets to try and help, which is also a common thing that you should probably know about. You don't need to know any details about it, but just know that it's something they use for epilepsy, especially in children. Cool. All right, so we'll talk about the different types of seizures and how we treat them. So we'll start off with partial seizures. So as we were talking about before, seizures happen when we have abnormal neuronal firing in the brain. Partial seizures happen when they start locally in one part of the brain and they stay in that part of the brain. They don't go anywhere else. That firing isn't traveling or spreading anywhere else throughout the brain. And then we can further classify it into simple and partial ones. So in simple seizures, the easiest way to learn it is that you're going to remain conscious. They know what's happening. In complex seizures, they're not going to remember what's happening. They're going to have impaired consciousness. And with the complex ones, they've got the temporal lobe epilepsy is the most common kind of seizures that you'll be seeing. And again, you get those very common signs, so motor signs, sensory symptoms, and autonomic symptoms as well. So they might like pee themselves or something like that. Cool. Then we have our generalized seizures. So as opposed to our partial seizures, we stay in one part of the brain, they're localized. Generalized seizure, as the name suggests, is going to spread throughout the whole brain. It's going to involve the whole brain. And we're more likely to get loss of consciousness. In fact, almost all people get loss of consciousness. And we can divide them into tonic-clonic or mainly absence and petit mal seizures. Tonic-clonic can also be called grand mal seizures, if that helps you remember it. But that's our, I guess, stereotypical seizures. That's where they have that spasming of muscles. They're like shaking around, flailing around kind of thing. That's what's going on there. In absence and petit mal seizures, it's kind of different. They're not doing that. They kind of just stand there. They stop moving and they just stare into space. And that's much more common in children than it is in adults. There's all these other kinds of seizures, but you don't really need to know about them. Yep, cool. All right, so status epilepticus. This is the third type that we'll be talking about. So this is when a seizure is lasting really long, so more than 5 minutes, and not self-resolving. We have multiple seizures that are close together, And so we can't really tell the difference. They just almost blend in with each other. Usually they're tonic-clonic, and this is usually precipitated by people who aren't taking their drugs, or the drug dose isn't sufficient enough, and we treat it with benzodiazepines, which we'll talk about a bit later. And then our post-seizure symptoms. So what's going to happen after our post-seizure symptoms? So we get, again, that confusion that I was talking about, but we can also get paralysis of our arms and legs, and that's called Todd's paralysis. So that's just an buzzword to know or be aware of. And that's because we've had that expectation, we've had that polarization, we're going to be depolarized, hyperpolarization now, sorry. And so like certain parts of the brain aren't going to be working as well, and so we get paralysis. All right, so neurochemistry and pathophysiology of how things are working. So there's two things that are causing all this abnormal firing in seizures. So either we have too little inhibition or we have too much excitation. We have inhibition is mainly potentiated by GABA, neurotransmitters and GABA, and through GABA receptors. And so if we have too little of that, we're going to get too much excitation and we're going to get seizures. If we have too much excitation, which is precipitated through glutamate and NMDA receptors, we're going to get too much excitation and then we're going to get seizures as well. So our antiepileptics function by trying to reduce these two things. So if we have too little inhibition, we're going to try and make more inhibition. We're trying to enhance that neural inhibition. If we have too much excitation, sorry, we're going to try and reduce that excitation. And there's a few mechanisms we do that through. Either we're going to inhibit glutamate transmission via our NA channels or calcium channels, or we're going to enhance our GABA transmission through a bunch of these drugs. Let's talk about them one by one and try and do it systematically. So we'll talk about the ones that inhibit glutamate transition first. So we'll start off with carbamazepine. So this is one of the most common drugs that they're using. So we inhibit glutamate transition by blocking those sodium channels, those Na voltage channels. And this will preferentially block our high frequency neurons, the ones that are firing most frequently, which are the ones that are affected in seizures. Those are the ones that are firing. So those are the ones that are problematic. You get a bunch of different symptoms. There aren't too many to know, too many that you should actually be remembering, I think. But I think the big one is probably drowsiness. So if you're getting inhibition of neurons, things aren't going to be firing. So sleepiness is kind of not too hard to associate, or drowsiness not too hard to associate with carbamazepine. And the main indication we use it for is for partial seizures, which is important to know as well. Next, we have phenytoin, does the exact same thing, but it has a different different way that it's different pharmacokinetics. So we've got zero order kinetics, which means that it's much harder to dose. It means that things are more likely to accumulate because we've only got a set amount of enzyme. It's not going to increase in relation to the amount of phenytoin that we're administrating. So it's more likely that we're going to get toxicity with phenytoin. So it's a really dangerous drug, I guess. You're more likely to get adverse effects. Again, you can get that drowsiness kind of thing, but the most important one that you should know is gum hyperplasia. That's a really common question for them to ask you, like what is the side effect of phenytoin? That will probably be the answer. The other ones are kind of just things that happen, not worth remembering in my opinion. And then we've got ethosuximide. So this is also going to inhibit glutamate transmission, but it's going to do this by blocking our calcium channels, our T-type calcium channels. Okay. And the main indication for this one is absence seizures. So this is also a common question for them to ask the person's having an absence seizure, and the question that asks you what drug is most appropriate, and often it's mostly ethosuximide. And again, you can get a wide variety of adverse effects that probably aren't worth remembering. Valproate. So we're going to start looking at the ones that inhibit GABA transaminase. So this is an enzyme which is going to break down GABA. And so if we stop the breakdown of GABA, we're going to have increased amounts of neuronal and extraneuronal GABA. So we're going to have more inhibition at the neuron. It also can block sodium channels, but this isn't its main effect. Its main effect is inhibiting GABA breakdown. You've got a bunch of side effects. Main one here is probably weight gain, increased appetite, and hair loss and alopecia. Those are things that I think you should know about. Cool. Tiagabine, same thing, does the same thing as Valproate, it's not a core drug, so I don't think you need to know it. It has the same side effects. So if you see Valproate, kind of just remember it as the same thing as tiadrine, basically. It's not in your e-pharmacology, so I don't think you need to know too much. All right, then we have clonazepam. So that's a benzodiazepine. So this is what I was talking about before. One of those drugs that we can use for emergencies where we have that status epilepticus, because it's really strong. And again, it's going to increase, instead of inhibiting the breakdown of GABA, we're going to increase our potentiation by increasing chloride permeability. So it's basically going to make the effects of GABA stronger at the synapse. And that's going to mean if you have more entry of if you have increased chloride permeability into the cells, it means there's increased negative charge, which means it's more hyperpolarized in comparison to the extracellular environment. So it's more inhibited and it's less likely for a neurotransmission to go across that synapse. Some of the things that you need to know about adverse effects, probably sedation is the biggest one. We'll talk a little bit more about benzodiazepines as they're used in other conditions as well. Yeah, and then we've got phenobarbital, same as clozapam. It's going to do the exact same thing. It's a barbiturate though, so barbiturate, barbiturate, and it's going to have the same side effects. So you don't really need to focus on that because it's also not core. All right, this is a summary of all the drugs. Sorry for the bad screenshot, but I had in my notes, so that's what we'll work with. As you can see, there's drowsiness across the board, across most of these drugs. So if you have to guess, that's probably a good one to note. Weight gain is going to be in valproate and vigabatrin. You don't really know about vigabatrin, but the V ones are going to have weight gain. So the weight gain is probably how I remember it. And then the other one is your phenytoin. So it's going to have that difficult pharmacokinetics, that zero order kinetics, as well as the gingival hyperplasia, which I think you definitely need to know about. Is associated with phenytoin. All right, so this is basically a table just highlighting what we're going to be using for each type of seizure. So generally, partial seizures either carbamazepine or valproate, more commonly carbamazepine. For generalized tonic-clonic seizures, we're going to use valproate mainly. Absent seizures, we're going to use ethosuximide, or we can use valproate if that's not working. And then for the other ones, we can use vigabatrin. All right, Parkinson's disease. So Kevin's already kind of talked about it. But it's a chronic neurological disorder. The main symptoms you need to know about are resting tremor, rigidity, akinesia, bradykinesia, or postural instability. Pretty common, idiopathic causes, but there might be some environmental toxins that cause a genetic susceptibility, all that kind of stuff, multifactorial. Pathophysiology, this is like big. So there's a loss of neurons in your substantia nigra, which leads to a loss of dopamine in that striatum, in those pathways in the basal ganglia, which you do need to know about. That's like big core for second year, I think. And it's really important because it's kind of like a progressive loss of dopamine and those nerves. So as you go down, you're compensating for your symptoms up until you reach 20% of your nerves being left. And that's when you start to see the actual symptoms of Parkinson's disease kind of manifesting and quite obvious. So once we get below 20, it's kind of mild. And then once we're getting below 10, that's when it's like really quite serious Parkinson's disease. Kevin's already talked about this stuff, but this is the pathways that you need to know. Basically, you're just losing all your dopaminergic neurons. You're losing dopamine, and that's going to lead to less stimulation in this pathway, less movement in this pathway. Cool. Pathology, the histopathology that you need to know, you're getting a buildup of alpha-synuclein, and that's going to form Lewy bodies. You never really have Parkinson's disease without Lewy bodies. So that's something that you should need to know about. It's kind of a buzzword for Parkinson's disease that will come up again and again and again in the future. All right, so these are the clinical features I talked about. So that pill rolling tremor, rigidity, so cogwheel or lead pipe, that's what you look for in your neuro exam. Akinesia, bradykinesia, postural instability, micrographia, so their writing becomes smaller. They have a shuffling gait, hypomimia, so their facial expressions are reduced, their voice is reduced, and then they get cognitive features, which a lot of people don't really notice, but that's a big thing in Parkinson's as well. It's very common. Okay. Pharmacological management. So how are we going to treat this? So there's first line, second line, and other that we're going to be using. So the main ones we use are levodopa, carbidopa. and then we can use, and that's basically just going to increase the amount of dopamine. They're basically dopamine analogs, which are going to mimic the effects of dopamine. Then we've got our second line, which is pramipexole mainly. That's going to be a dopamine agonist at the receptors, and then we've got all these other ones that we'll talk about later. We can also have surgical management, but that's not used as often because it's kind of new, innovative, and it's a bit more invasive. So that's why we just use our standard pharmacological drugs. Cool. So we'll talk about levodopa and carbidopa first. It's important to note that they're two different drugs. So what is levodopa? It's a metabolic precursor to dopamine. So it's a thing you get before you get dopamine, and it's converted to dopamine by dopa decarboxylase, which is a really important enzyme in your nigrostriatal pathway. And the reason why we put levodopa instead of actual just dopamine, we don't just give them dopamine, is because dopamine can't cross the blood-brain barrier. That means our dopamine isn't actually going to get to our brain if we just give them dopamine. So we give them a precursor that can cross that blood-brain barrier. Adverse effects, this is basically what's going to happen if you have too much levodopa. So if you have, it's basically the opposite of Parkinson's. So you're going to get excessive movement. You're going to get nausea, vomiting, because you're going to have dopamine receptors in your stomach, which is stimulated when you get nausea and vomiting. End of dose deterioration. So once the effects of levodopa wear off towards the end of the dose that you give, they're going to have their Parkinson's symptoms kind of remit. Hypertension, hallucinations, and you kind of get this tolerance which builds up over time to levodopa. So we've got, when we were talking about peripheral DDC, DDC exists not in the brain, not only in the brain, but it exists in the peripheries as well. And if we just gave levodopa, 99% of it's going to be metabolized in the periphery. So that means 99% of that levodopa isn't going to get into the brain, which means we have to give something that's going to stop that so all our levodopa can get into the brain. So we give them carbidopa, which is a peripheral DDC inhibitor, which is going to stop that enzymatic transformation of levodopa to dopamine in the peripheries and allow that levodopa to cross that blood-brain barrier and go to the brain first. This isn't really that important, but basically levodopa just changes the receptor sensitivity because you're giving them pulsatile levodopa dosing, and so you can get real fluctuations in how your dopamine levels actually are, which means they can get like times where they have no symptomatic remission at all, and times where they've got too much symptomatic, so they're getting their dyskinesias and things like that. All right, other drugs that we use. So if we don't, levodopa and carbidopa is not effective, we can use other things like pramipexole. So this is a direct dopamine agonist. It's going to directly activate those dopamine receptors in the basal ganglia. And it's really good because it's got a longer half-life. We've got less likely to have side effects. And we don't have to think about that metabolism and those metabolism considerations. The most important adverse effects is that it's really good at causing nausea and vomiting because it's going to be acting on both your peripheral dopamine receptors in the stomach that I was talking about mainly, as well as the brain. So we can give them domperidone, which is a peripheral dopamine antagonist in combination with that. And that doesn't cross the blood-brain barrier, so it's not going to affect our Parkinson's symptoms, but that can stop our nausea, vomiting, and hypotension, which is really, really good. Other dopamine agonists that you need to know about are apomorphine and bromocriptine. Apomorphine is hypometagenic and administered subcut, and bromocriptine is really good at causing impulse disorders, so things like gambling where people don't have control over themselves. Yeah. All right. So other drugs, these are less commonly used now. This is kind of getting into lower yield. Well, we've got selegisline. So this is an irreversible inhibitor of MAO-B. MAO-B is going to be breaking down dopamine. So if we're going to inhibiting MAO-B, we're going to be inhibiting the breakdown of dopamine. So we're going to have more dopamine at that synapse. Again, it's going to have all those similar sort of side effects, so dyskinesia, nausea, vomiting, orthostatic hypotension. But it's going to also have serotonin toxicity if you give other serotonergic drugs, because dopamine is also kind of associated with those pathways as well, which is important to note. And entacapone, so this is something that blocks CoMT, and that's an enzyme which breaks down levodopa. So if you block the breakdown of levodopa, we're going to have more levodopa, which is good. Again, similar side effects that you can kind of just they're broad brush side effects. So they are similar across all of these drugs, basically. Amantadine, so we don't really know this drug's side effects, but we know that it does increase our dopamine release and block the reuptake. Probably the biggest side effect that they might ask about is libido reticularis. Yeah. And this is also used for, I think, viral infections as well, as an antiviral drug, but that also is not known, the mechanism of action. Benzotropine. So dopamine is also closely linked with our cholinergic activity. So dopamine inhibits our cholinergic activity. When we have Parkinson's, we don't have enough dopamine, so we're going to get lots of cholinergic activity, and that's going to lead to some of the symptoms. So we can use an anticholinergic to counteract all of that and provide some symptomatic relief. But the side effects of that are our muscarinic sludge, so our dry mouth, our constipation, our urinary retention, and our blurred vision, which are all really, really common with all anticholinergic, all muscarinic antagonists. So this one's not as hard to learn, I think. But these are mainly for symptomatic relief. This is a diagram to highlight all of what I've just said, if you like visual formats. All right, so Huntington's disease, Kevin has already talked about it, but it's autosomal genetic disease. There's no real cure for it, characterized by chorea, so there's unpredictable movements. And people usually die from it. There's no cure. Caused by an increase in CAG repeats, which is the main kind of pathology. And the pathophysiology is kind of opposite to our Parkinson's, because we've got dopamine hyperactive. We've got too much dopamine almost, because we've got a loss of our GABA neurons, a loss of our inhibitory neurons. And that's all you pretty much need to know. And these are some of the drugs that we use it, but they're not very effective. All right, anxiety. So this is something that I'm sure we're all kind of very familiar with in our own lives, but it's a normal emotion, unsettling feeling, common in females, people who are 20-year-olds, so like us. And it's got a strong genetic component, clinical features, restlessness and agitation, things that you'd imagine in an anxiety attack, so tachycardia, sweating, nausea, sleep disturbances, and weeping. So not much to know here. This is all kind of common sense. I wouldn't put too much into this. Pathophysiology, though, is pretty important. So it's mainly characterized by GABAergic hypofunction. So if we've got less GABA, less of our inhibitory neurons, we're going to get overactivation of our brain neurons, basically. We're going to get overactivation of certain pathways in our brains, and that's what we're going to have to be treating. So usually we can just start off with conservative management, counseling, exposure therapy, CBT, all that kind of stuff. But then we can start using, if that's not working, we can use benzodiazepines or antidepressants as well sometimes. So we'll talk about benzodiazepines first. As we were talking about before, they enhance our GABA activation. They increase our inhibition and potentiate GABA. So they're going to have more inhibition. Clinical effects, they're going to reduce our anxiety. They can produce sedation and sleep as well as that, and reduce our muscle tone as well. And they can also be used in epilepsy, as I was talking about before, especially in the immediate sense. Adverse effects, so drowsiness, anti-retrograde amnesia, so we can't create new memories and retain them, and then we can start to get tolerance as well. And people don't really know if this is a good treatment for anxiety and insomnia, because people can get very tolerant and dependent on it, and people don't even know if they actually feel better after using the benzodiazepine. So it's very controversial. All right, so sedatives, hypnotics, and anxiolytics are all kind of related a little bit, based on how much dose you're using and the half-lives of the drugs. So in general, if you want to have anxiolytic effects, you're going to have drugs that have longer half-life. They're going to last longer. In general, they'll be kind of weaker in the actual sedative effect that they're going to be producing. But if you want to have things that are inducing sleep and helping people get to sleep and stopping insomnia, then you can use things that have a shorter half-life, such as like midazolam and temazepam, things like that. So there's kind of a scale of these drugs. And another thing that you need to know is what's the difference between sedatives and hypnotics. So sedatives are kind of the low dose version of anxiolytics, and then there's hypnotics, which are the high dose versions pretty much. So sedatives are going to have calming effects, reduce our anxiety. They don't really have an effect on our cognition or mental function, whereas hypnotics are the high dose anxiolytic drugs, and they're going to encourage drowsiness and sleep. They're very important. Their effects are dose dependent pretty much. And we can have a whole range of different effects, which I think I talk about, on this slide. So general anesthesia is basically when we're using strong, high dose anxiolytic drugs. And there's a few ones we can use. There are a few different types of drugs. But the triad that you need to know that they're producing, the effects that they're producing, is hypnosis, analgesia, and muscle relaxation. And most of them can do some of them can do all of them, but not many. Most of them only do one or two. There's some phases of anesthesia that you need to know about. So you need to know about induction. So that's when they're getting into the anesthetic phase. Their excitement, so they're getting this irregular breathing. They're starting to get amnesia, getting some amnesia. Then you've got your surgical anesthesia, so they've lost their respiration. You're respirating on their behalf. So that's why they have the breathing mask and things like that. And they don't have any reflexes. And usually at the end of a surgery, they'll stop that and they'll stop the anesthesia and they'll recover. But if they don't stop the anesthesia, eventually it will just go on forever and they'll get cardiorespiratory depression eventually and they'll die. Things that we like in anesthetic drugs, if we have rapid induction, because faster is always better. We have wide therapeutic window, so it's not hard to do the dosing. And if we have minimal toxicity and adverse effects, because common sense. All right, so some of the properties of IV general anesthesia. It's very rapid as opposed to the inhalational anesthesia, it's the ones that you breathe in because it's going to IV. And so it's really good for induction, but because it's good for induction, it's not as good for maintaining your anesthesia. It's only good for starting your anesthesia off. All of them are lipid-soluble molecules. So these are the drugs that you need to know about that we'll be talking about. So we'll start off with thiopentone. This is a short-acting barbiturate. It's going to have the same effects as amplifying the effects of GABA at the receptors. Very, very quick, but it wears off very quickly as well because it's readily redistributed to other compartments of the body. It's not actually broken down, it's just redistributed. And that's what's causing the short effect time, duration of action. We've got propofol. We don't know how it works, but we think it does the same thing as thiopentone. It's a bit longer than thiopentone. It's useful for short surgeries. There's some of the adverse effects. You don't really need to know about it. A bit longer acting is ketamine. So this has a different effect. So it's an antagonist at our NMDA, at our excitatory glutamate receptors. So it's going to be blocking the excitation instead of increasing the inhibition pretty much. It can also affect muscarinic and opioid receptors. So you're more likely to get side effects if you do have, if you're using opioid and anti-muscarinics as well, because they're all acting on the same receptors. And because of that, because it's acting on opioid receptors as well, it can also have useful properties in painful procedures where you want to reduce the amount of pain. There's a bunch of different side effects that can happen, pretty much like everything that you can imagine. But probably one of the most important ones are the hallucinations and delirium that happen after you recover from ketamine, as well as the urinary tract symptoms. So a lot of people have painful urination or increased frequency or hematuria, which is quite common after using Ket. Then you've got midazolam. So this is the benzo as well. Does the same effect as we've been talking about. This has more likelihood for cardiovascular depression than the other ones. Again, you're going to get similar side effects that we don't really need to talk about, and tolerance. So people can build up a tolerance over time. So all of these, like the effect, the long term, how long they last, basically has been increasing as we've been going through these drugs. This is a table to summarize all of that. We won't dwell on it. Okay, so as opposed to IV anesthesia, we can have inhaled anesthesia, and that can be either gas or volatile liquids. The mechanism is unknown, but we think it's due to activation of TREC channels. So because we've got potassium efflux, we're also going to get hyperpolarization of neurons. Usually they're very chemically inert and lipid-soluble molecules, and the potency is really related to that. Potency is measured through their minimum alveolar anesthetic concentration. So this is basically how much, what the concentration of inhaled gas that they need in order to result in immobility. So the lower the number of this MAC, so the lower the concentration they need, is the higher the potency. And it's important that the recovery is through these drugs being redistributed to certain compartments rather than actual metabolism of these gases or volatile liquids. There's a really important kind of, statistical marker that we use or measure that we use when looking at inhaled anesthetics, which is our blood gas partition coefficient. And that refers to the ability of an anesthetic drug to diffuse across the lungs into the blood. So it's basically talking about how much anesthetic is in the blood compared to the alveoli. So if we have a higher coefficient, a higher amount is in the blood, which means it's more hydrophilic, it's more soluble in the blood, and so it's going to have a slower induction because it's going to be less likely to pass through that blood-brain barrier because it's more hydrophilic. It's going to stick in that. And so the common one, the most slowly inducted, inhaled anesthetic is halothane. And as opposed to that, we have drugs which have a lower coefficient. So we have a lower amount of anesthetic in the blood, which is more lipophilic, which means it's more likely to go through the blood-brain barrier and more likely to have a faster induction. So the common one that we think about is nitrous oxide. So if it's more lipid soluble, it's more likely to go through that blood-brain barrier. All right, so this is a table kind of highlighting things. So again, less soluble in the blood means it's more likely to go into the brain. Potency is kind of related to your solubility. So if it's less soluble, it's less potent. If it's more soluble, it's more potent, pretty much. All right. These are some side effects that you need to know about. I wouldn't worry too much about them. Nitrous oxide is kind of common sense because if you're giving them things that aren't oxygen, they're likely to have less oxygen in their blood, which makes sense. Cool. Next is depression. So depression is, again, things that we'll be very knowledgeable about, I'm sure, but it's a disease character or disorder characterized by certain symptoms, and you can classify it on a spectrum. Very common, more common in females, associated with family history, and again, our age group. There's also a bunch of other different risk factors that you need to know about, but I'm sure you've heard of them before, so I won't dwell on them. Diagnosis is according to DSM-5 criteria. So all these kind of criteria, but they're also kind of common sense ones. So depressed mood, loss of interest in things, weight changes, sleep changes, fatigue, concentration problems, executive dysfunctions, guilt, worthlessness, or suicidal ideation. How we're going to management? Again, we're going to have a combination of non-pharm and pharm. So physical activity, diet, CBT, and psychotherapy. Or we can have, that's not working, we can elevate it up to pharmacological therapy. And the way that we do that is through our increasing the amount of monoamine neurotransmitters that we have in our body. So in order to understand how the pharmacology is working, we need to know what the pathophysiology is. So depression happens because we have not enough monoamines in our system. No monoamines means depression. When we have low amounts of monoamines in our body, we're going to upregulate our monoamine receptors. When we have high amounts of monoamines, we're going to have low amounts of monoamine receptors. So depression is associated with an abnormal upregulation of monoamine receptors, and that's going to result in a low amount of monoamine neurotransmitters that are there to begin with. And so we try and counteract that by increasing the amount of actual neurotransmitter or decreasing the amount of receptors in that body, whether that be through serotonin, noradrenaline, or even dopamine at times, but we don't use dopamine as much. Cool, so there are positive and negative effects that we can specifically target in depression. In depression, we have reduced positive effects due to mainly upregulation of noradrenaline receptors. So we have less of our good things, less of our good mood, less of our happiness, less of our interest and pleasure, less alertness, self-confidence. That's all going to be due to not enough noradrenaline and too much noradrenaline receptors mainly. And then we can have increased negative effects. So more of the bad things, so more depressed mood, more guilt, more fear, anxiety, hostility and irritability. And that's going to be because we're going to have too little serotonin. or too many serotonin receptors mainly. And so we can target those specifically. You don't need to actually be able to target things because you're not a psychiatrist, but just knowing that this is how they're working is important. So we'll talk about drugs one by one. There's a whole bunch of drugs, but they all kind of do similar things. We'll try and make it as easy as possible to learn. So we'll start off with our tricyclic antidepressants. These are the common ones. They're going to block our reuptake of noradrenaline and serotonin, mainly serotonin. All TCAs have at least 2 of these side effects, either muscarinic receptor blockade, histamine receptor blockade, or alpha-1 adrenoreceptor blockade. So muscarinic receptor blockade is going to result in those common symptoms of dry mouth, blurred vision, constipation, retention, and delirium. Histamine blockade is going to result in sedation, and alpha-1 adrenoreceptor blockade is going to result in our blood vessels not working properly. So we're not going to get as much constriction. We're going to get orthostatic hypotension and then a reflex tachycardia to try and compensate for that. Other things that we get is if we have too much serotonin in the synapse, we're going to get serotonin syndrome, which is characterized by these symptoms: so agitation, confusion, fever, diarrhea, tremor, shivering, sweating, and loss of coordination. And that's particularly when you give them other antidepressants as well. It's more likely to happen. Cool. Tricyclic antidepressants, so mirtazapine, it has even though it does have the same chemical structure, it works more so on blocking our alpha-2 adrenoreceptors. Side effects include blocking our histamine receptors as well as our alpha-1 receptors, so you're going to get sedation and your orthostatic hypotension. Then we've got our fluoxetine, which is an SSRI, so selective serotonin reuptake inhibitor. So it's going to selectively block reuptake of serotonin into the presynaptic neuron. So you're going to get increased levels of 5-HT, and then it's going to downregulate those postsynaptic receptors. You don't need to know the specific side effects, but you need to know that, again, you can get serotonin syndrome if you combine it with other drugs that you're not dosing it properly. Venlafaxine, so this is a serotonin and noradrenaline reuptake inhibitor. It's going to do, as the name suggests, block the reuptake of serotonin and noradrenaline, but more so works on serotonin rather than noradrenaline. Again, you can get serotonin syndrome, but the good thing about this is you don't get the muscarinic histamine or alpha-1 adrenoreceptors as much as you do the TCAs. In fact, you can get quite the opposite. So you can get tachycardia, hypertension, and prolongation of the QT interval, as well as these other things. Moclobamide, so this is a REMA, this is a reversible monoamine oxidase inhibitor. So reversible inhibitor of MAO-A. What does MAO-A do? MAO-A metabolizes our noradrenaline and serotonin. If we block MAO-A, we're going to get more noradrenaline, more serotonin. That's going to increase the amount of synaptic serotonin and noradrenaline, and it's going to downregulate those monoamine receptors. So we're going to prevent depression, basically. Side effects, again, some of those muscarinic ones, nausea, vomiting, all that kind of stuff. Very vague side effects. Phenylcypramine, so as opposed to being a reversible monoamine oxidase inhibitor, this is an irreversible monoamine oxidase inhibitor. And it's more long-lasting, basically, and the effects don't wear off until the enzyme is actually resynthesized. And this is actually really important. The most important side effect here is that you can get cheese reaction, so hypertensive crisis. So you can get like headaches, elevated blood pressure, and like focal neurology, like blurry vision, things like that, because of the tyramine in the cheese, which is also metabolized by MAO-A. So if they're all being metabolized by MAO-A, some of them are going to build up eventually. Okay, there's reboxetine. That's a noradrenaline reuptake inhibitor that selectively blocks reuptake of noradrenaline. There's nefazodone, which is a SARI, so a serotonin antagonist and reuptake inhibitor. So it's going to not only block the reuptake of serotonin, but block their receptors as well, which is also used in anxiety. It's less potent than the SRRIs and the TCAs as well. Not important. The side effects. These are certain indications in other disorders that you might use antidepressants. So there's a lot of overlap between antidepressants and anxiolytics. when we're actually using them, but you don't need to know that kind of stuff. Okay, bipolar disorder. So as opposed to depression being a unipolar disorder where our mood is only in one direction, we can have bipolar disorder, or our mood is in two directions and it's alternating. So it's depression alternating with mania. That's the main part of bipolar disorder. Way that we treat it, we use lithium. We don't know how it works exactly, but it's thought to permeate those sodium channels and block those permeate sodium channels so they're less likely to depolarize and hence stabilizing our mood. Yeah. You don't really need to know about the adverse effects, but it just causes a lot of bad things, like nephritis, glomerulopathy, diabetes, insipidus, tremors, and things like that. So it's not a good drug to be using. It's a very dirty drug. OCD, recurrent obsessions and compulsions, very common sense, can become time-consuming, interfere with normal life. You don't need to know too much about it, just what it is, and how to guess it and characterize it based on symptoms. All right, schizophrenia. I think we're getting towards the end of neuropharmacology. I can't remember how many slides I put in here. But schizophrenia is mainly a disease characterized by disruptions in people's thinking, as well as psychotic experiences. So that's hallucinations and delusions. So hallucinations being things that you can see and hear and smell that aren't really there, and delusions being relating to ideas that aren't true, that you believe in. Very common. Again, very strong genetic factors in, and family very implicated very heavily in it, but there's also environmental factors like how we grow. So it's very multifactorial disease. Pathophysiology is mainly to do with elevation in dopamine. So it's a little bit kind of the opposite of Parkinson's, where you have not enough dopamine. And dosing, how our drugs work is all going to talk about Parkinsonism as well. So that's mainly to do with our psychotic symptoms. And then hallucinations are to do with our serotonin receptors. So as seen in LSD, it's based on clinical diagnosis, based on positive symptoms, negative symptoms, and cognitive symptoms. So the main ones to know about: delusions, auditory hallucinations, disorganized speech, or bizarre thought disorders kind of things. Negative symptoms, so social withdrawal, lack of drive, blunting of emotions, and hedonia. And then cognitive symptoms, lack of attention, memory, and executive function. Pharmacological treatment, we can either use atypical antipsychotics or our typical antipsychotics. Atypical antipsychotics are the newer ones that we use, and they're generally better because they have less side effects. Antipsychotics are like the older drugs. They have more side effects, and they're less commonly used, but they are used sometimes. All right, so how does schizophrenia work? So what is the neurophys? What is the neurochemistry? There are a few dopaminergic pathways in the brain that you need to know about. So there's our mesolimbic / mesocortical pathway, and that's where our ventral tegmental area is. There's neurons going from there to our prefrontal cortex and nucleus accumbens, which is actually really important to know that these two are associated with this mesolimbic pathway. And when this pathway is disrupted, that's when we get schizophrenia. We've got nigrostriatal pathways, which is what's involved in Parkinson's. So we've got neurons from our substantia nigra through the striatum. And then we've got our tuberohypophyseal pathway. So this is where there's projections from the hypothalamus to the pituitary gland. And that's involved in how we're regulating prolactin. So it's kind of like not as important as the other ones, but it's still very relevant to mention. Okay. So antipsychotics, how are they going to be working? Because we've got disruption to those dopamine pathways, we've got too much dopamine in that mesolimbic pathway in particular, we're going to be using antagonists at those dopamine receptors to try and reduce those symptoms. In order to achieve effectiveness in how our dosing and drugs are working, we have to at least occupy 60 to 80% of dopamine receptors, which kind of makes sense because when we talk about Parkinson's, we had like this 80% as this magic number of receptors being affected or neurons being affected in order to show symptoms. So you can kind of use those as numbers to help you remember if you're struggling to remember. Adverse effects. So the adverse effects of antipsychotics, of these dopamine antagonists, are if they're acting on the other pathways. So the tuberohypophyseal pathway or a nigrostriatal pathway. So if we're having dopamine antagonists act in our nigrostriatal pathway, where our substantial nigra is, where our Parkinson's disease is implicated, we can get extrapyramidal symptoms, which we can otherwise call drug-induced Parkinsonism. So we get Parkinson-like symptoms, but no actual Parkinson's disease. It's just induced by drugs. We can get dopamine antagonists working in our tuberohypophyseal pathway. So if we are inhibiting those pathways, we're going to get increased prolactin in those pathways, which are going to give us our prolactin symptoms, such as gynecomastia, amenorrhea, things like that. And we can get other central blockades. So we can get not just in one or the other, we can get things happening in everywhere. Yep. So that's how the basic principles behind the adverse effects of antipsychotics. There's also some other side effects that we need to know about. So again, sedation associated with histamine receptor blockade, postural hypertension associated with alpha-1 receptor blockade, and then our muscarinic blockade associated with that muscarinic sludge. So weight gain, multifactorial, and also some metabolic effects that we need to know about. So the typical antipsychotics, these are the older drugs. They're also called neuroleptics. They do well for positive symptoms. They don't do well for our negative symptoms. And the two big ones, chlorpromazine and haloperidol, that you really, really need to know about. So we'll start off with chlorpromazine. So it's a dopamine receptor antagonist. It also has other effects on those receptors that talk about, so alpha-1, muscarinic, and our histamine receptors. But the important thing to note is that it's got lower potency at the D2 receptors in the nigrostriatal pathway. So you're going to see less extrapyramidal side effects as opposed to haloperidol, which is the other drug we're going to be talking about. And we've got higher potency at the acetylcholine receptor. So we're going to see more muscarinic effects and alpha-1 adrenal receptor effects as well in chlorpromazine as opposed to haloperidol. And that's really important. We've got some other side effects. So we've got our tuberohypophyseal side effects at the bottom. So those metabolic ones, we've got neuroleptic malignant syndrome, which happens with any of these drugs. And we've got our sympatholytic pathway, sympatholytic effects. So things to do with that alpha-1 adrenal receptor blockade. So this is all in comparison to haloperidol, which is going to have kind of the opposite. So it's still going to be a dopamine receptor antagonist, but it's going to have more extrapyramidal side effects. So it's going to be having more adverse effects in our nigrostriatal pathway and less adverse effects in our muscarinic pathways. It's also going to have some of these other similar effects, but because it has more extrapyramidal side effects, it's going to be completely contraindicated in Parkinson's disease. Because it's going to worsen their Parkinson's disease pretty much, because you're going to have too many extrapyramidal side effects. It's going to just be too much, and people are going to feel bad and they're going to have all the symptoms of Parkinson's pretty much. You're going to get no relief no matter how much levodopa and carbidopa you're using. Right. Okay. So this is a table highlighting all of what I've just said. So you still get all these effects in both, but the important thing to note is that you get less dopamine, less nigrostriatal effects in chlorpromazine as opposed to haloperidol. That's probably the big takeaway. If anything, it's a very common exam question that they'll ask you in your exams. Cool. Atypical antipsychotics. So these ones are not only working on dopamine receptors in, remember the nucleus accumbens that I was talking about, but they're also going to be working on the serotonin receptors in our prefrontal cortex. So the way it works is we've got dopamine receptors in our mesocortical pathway, mesolimbic pathway, and serotonin is going to be inhibiting this. So if we have too much serotonin, we're going to get less dopamine working, so we're going to get less stimulation of our prefrontal cortex. So our negative symptoms are due to our hypoactivation of our prefrontal cortex. So in order to counteract that, we need to block the amount of serotonin going in here. So we need to increase the amount of dopamine that's working and increase the stimulation of our prefrontal cortex. And then we've got our nucleus accumbens. So that's basically just due to the overactivation of the nucleus accumbens. So we want to be inhibiting those dopamine receptors in the nucleus accumbens. So this is what our atypical antipsychotics are going to be doing. They're going to have more selective effects on each of these particular receptors. All right. So we've got risperidone to begin with. It's going to be a dopamine receptor antagonist in that prefrontal cortex. It's going to inhibit our positive symptoms, and it's going to be also a serotonin receptor antagonist in our nucleus accumbens is going to reduce down negative symptoms. Again, you're going to get those similar effects. You're going to get alpha-1 adrenal receptor blockade, dopamine receptor blockade, but they're very, very much more unlikely as compared to your typical antipsychotics. It can still happen, but it's very much more unlikely. Yeah, and then all these other random ones. Olanzapine, same mechanism of action. It's more likely to cause your weight gain and hypoglycemia and your metabolic effects. Can still cause all the other ones, but very much more or less likely. And it's virtually almost doesn't cause extrapyramidal side effects at all. Clozapine, same mechanism of action that we've been talking about, but the main adverse effect that you need to know about is that it causes fatal agranulocytosis. That's when they don't have enough of their immune cells, basically, which means that they're very susceptible to infection. So that's why we don't use it as much as the other ones. So we only use it in people who have resistant or refractory schizophrenia. Yeah, cool. And then quetiapine. So again, same sort of things, same side effects. And then there's aripiprazole. So it does a partial of both, and it's less likely to cause side effects because of that reason, which is why it's like a new kind of drug that people are liking. But it's not on your ePharmacology, so it's not core, but it's just something interesting that you might want to know about. This highlights all the same things I've been saying, less side effects pretty much. It actually causes less side effects than is illustrated in Richard's diagrams, but this is what Richard gave, so maybe go by whatever he says. All right, so that's the end of Neuropharm. I'll throw it over to Kevin. Yeah.
For the conclusion. So this is microbiology. Can you see that properly? I'm going to assume yes. Okay, cool. So this is microbiology. It's not the most intensive ever. The meningitis stuff is important. The rest of it is, and the LP stuff is important. The rest of the random conditions, a little bit less so, but we'll talk about each of them anyway. So this is just an overview of terminology. Refer back to this when you want or when you need. But basically, the different terms represent different things. The two most important ones, meningitis and encephalitis, mean different things. So meningitis means inflammation of the meninges, encephalitis means infection of the brain itself, so the parenchyma of the brain. So this is some principles of CNS infection. So the general idea is that CNS is a privileged area and it should be sterile. The CSF shouldn't have anything in it. It's protected by the blood-brain barrier, but there are two locations where, I guess, injury and things can cause bacteria to get in. These being the cribriform plate, where your olfactory nerve passes through, and your inner ear via the vestibular cochlear nerve. And those are two sites where the CNS can become infected through. And it's infection of the CSF that we are looking through, or goes into the CSF. These obviously, as we kind of talked about before, circulating the ventricles and subarachnoid space. Dermatomes are also important, and devices that enter the CNS are also likely sites of infection. So if they put a drain or a tube into the ventricles, be that to look for ICP, to kind of pressure, or to drain fluid out, or even an LP that can cause infections because we're introducing foreign objects in. For those cases, the most common causes are apparently a coagulase negative staph. For dermatomes, we're looking mostly at shingles, causing that rash that is in a dermal tone pattern that causes the pain. In terms of some general clinical manifestations, they are different time courses, but generally speaking, they'll have a fever, a headache, altered mental states, and focal neurological defects. We'll go into specifics in terms of conditions, obviously go through meningitis and encephalitis and the like. You also get focal neurological effects, such as Ramsay-Hunt syndrome, which is just shingles of the facial nerve, basically. And yeah. Cool. So this is some important factors, I guess, or things to look at when we're looking at CNS infections. Basically, it's not that useful. This, I think, is looking for infective endocarditis in terms of why you're looking for cardiac murmurs. These are your signs for meningitis and looking for, I guess, meningeal inflammation. But these are, I guess, interesting. Rashes are important. So these are your non-blanching purpuric rash associated with meningococcal septicemia, associated with meningococcal meningitis, caused by Neisseria meningitis. But those are just some details that you might be interested in to look at. So importantly, one of the most important investigations for CNS infections is a lumbar puncture. And it's important because we want to see what's growing or what's happening inside the CSF. For most people, or for some people, a CT will be done beforehand and to ensure that there's not raised intracranial pressure. And we care because if there perhaps is, there's a potential risk or a theoretical risk of coning, whereby, hopefully we talked about this before, but the brain herniates through the foramen magnum. And as such, if there's any signs of increased intracranial pressure, such as papilledema, headaches, or any kind of confusion, that kind of thing, or anything we might suggest there might be raised intracranial pressure, we might want to do a CT scan beforehand. We might also do it just looking for other causes, perhaps of a seizure, be that tumors or anything else. And perhaps MRI can also give more information about other things. But realistically speaking, CT scan before an LLP is to look for raised intracranial pressure or causes of. On that LP, we're doing a gram staining culture alongside biochemistry, alongside cultures and PCRs for other things as well. You'll also do a blood culture because it's an infection, and you always do blood cultures for infections. So for lung puncture, it's done at L4-5 as the cortical begins at L1. That's effectively what you're trying to do to avoid punching a hole to the spinal cord, which is quite bad. You'll pass through these layers, and that's kind of important because they might ask you these layers. So do commit these to memory. But basically, these ligaments are the only thing that's different, I guess. So there's supraspinous, interspinous ligament, and ligament of flavum. And they will pass through those layers into the subarachnoid space. These are the criteria, and this is just, I guess, the detailed look. But this, realistically speaking, is the slide you need to know. So on initial appearance, the bacterial ones will look cloudy or pussy, I guess, because there's cells involved. The open pressure will be raised, which isn't really that specific, and white blood count will be raised, which isn't that specific either. The next second factor that's useful is neutrophils, so bacteria, lymphocytes for anything else. And protein is raised for all of them. And then the second thing is glucose. So glucose will be low in bacterial because they're eating it. Same with TB. They're basically consuming the glucose, causing it to become low. Differentiating between bacterial and TB, we're looking at lymphocyte counts. But we're looking at other things in general. This is the kind of the worded form of that, basically. This is important. There'll almost certainly be a question related to this. It gets asked a lot, so make sure you know this, especially difference between bacterial and viral. And in terms of general management principles, empirical antibiotics are used for acute bacterial meningitis. Surgical drainage can be used for abscesses because antibiotics don't really go into abscesses very well. Adjuvant therapy, so additional therapy includes corticosteroids, including dexamethasone, to just reduce that kind of inflammation going on. You might also need to manage intracranial pressure, anesthesia medications, and fluid management depending on what's going on. But for acute meningitis, it's an inflammation of the meninges. It presents classically with fever, headache, and meningismus, so your neck stiffness and your photophobia. These three are quite classical for acute meningitis, so fever and your meningism plus your headache. They're important. You can get an altered mental state, but that's a little bit more common with encephalitis, which I think we'll talk about in a second. Most commonly, the cause is bacterial. They present within a couple of hours. And these bacteria are generally encapsulated, including your Haemophilus influenza types, meaning those patients with a spleen removed will struggle with, because that's what the spleen does. They deal with encapsulated bacteria. There's also viral and other causes, but they aren't as important. So your acute bacterial meningitis is primarily caused by Neisseria meningitidis, as well as Streptococcus pneumonia and your Haemophilus influenzae. These are your three main causes that you need to know. There's some other groups that you can care about. In neonates, you can also get group B strep, E. coli, and Listeria. In the elderly, you can also get that Listeria. Haemophilus isn't as common these days, but we'll go into these three primary pathogens in a second. In terms of treatment, dexamethasone is given before the antibiotics. Afterwards, it's not very useful, but that's not really that important for you. And you give ceftriaxone. You can also give benpen if it's Listeria, but that detail isn't necessary. This detail is barely necessary for you guys, but it's IV antibiotics, and that antibiotic is ceftriaxone. Streptococcus pneumoniae. So this is a gram-positive diplococci. That's important to know because they'll probably give you a slide and you guys to look for it. These are the risk factors for it. Basically, diabetes gives you a risk factor for most things. Asplenia because they're encapsulated. Hypogammaglobulinemia because you have low antibodies. And chronic liver disease, again, because you have low antibodies. Yeah, so basically just no gram-positive diplococci. That is your differentiating factor. Now, serum meningitis is a gram-negative diplococci, so that's why it's different from Streptococcus pneumoniae. They have a whole bunch of different groups, but the most common ones have a vaccine against it, so ACW, and this was kind of used. These can cause invasive meningococcal disease, causing meningitis with septicemia, and that will cause you to have a rash. So if they have a rash, classically described as non-blanching and purpuric, then it's Neisseria meningitis, especially if they then give you the gram-negative diplococci. And then finally, Haemophilus influenzae is a gram-negative coccobacilli. And this is, I guess, a common type. However, it's less common nowadays because of a vaccine given to children at a very young age. There's a classic risk factors, but realistically speaking, this is what you need to know. The fact that it's a gram-negative coccobacilli. Listeria monocytogenes actually is also here. It's a gram-positive rod bacilli, most common in neonates or elderly, so the extremes of age. This requires benzylpenicillin to treat, but it's basically this. All right, so acute viral meningitis is caused by other things. So non-polio enteroviruses, herpes viruses, HIV, and et cetera, et cetera. Mumps will give you salivary enlargement. HIV will have a history of it generally in terms of things that will give it away, as well as other things as well, the history. Enteroviruses are a single-stranded RNA virus, leading cause of aseptic meningitis, basically meningitis which doesn't have a bacterial cause, not necessarily non-infection. These are group B Coxsackie viruses, which is kind of important. Echoviruses is a little bit less so, but they are there. It's not necessarily that bad in people who aren't babies, but in the babies or the neonates, it can be problematic, causing multi-organ failure. And it's diagnosed on PCR, as are most viruses. Other causes of acute meningitis include syphilis, as well as the other random bacteria or organisms. Not very important. The most important thing is these three causes, and that's kind of mostly what you need to know. Where was I? Okay, so subacute and chronic meningitis might occur over weeks to months. They present with very similar symptoms, but they will just last longer. These are caused by your weirder infections, your mycobacteria or your fungi, and you kind of want a HIV infection. Look for an HIV infection because it might be the reason why it's subacute and chronic. So one of these causes Cryptococcus neoformans, which is a type of fungi or a yeast caused by inhalation, and causes cryptococcal meningitis. This isn't critically important, but it's diagnosed on an India ink stain. Basically, it will show up with like a white spot, a black slide. It occurs in HIV positive people, and it requires a lung puncture for therapy as well as different treatment. That's that. Tuberculosis meningitis, as from the TB pathogen. Again, diagnosed on CSF, and you're expecting TB everywhere else as well. So if it's in the meninges, you're probably expecting the lungs, but in saying that, TB can do whatever it wants, so it doesn't have to. All right, and then syphilis. So this generally occurs post the primary stage after many years, and it can be asymptomatic, but it can present with all these variety of different symptoms. Just be aware of these if they have a history of syphilis. You're then looking for HIV and other STIs, but it's done in serology, realistically speaking. And then neurocysticercosis. This is caused by a tapeworm. I think the most classical thing is these holes in the brain, which is a bit creepy looking, but it's a thing. And these are caused by cysts, and when a cyst, I guess, burst and die, it causes inflammation, which causes these holes. These can cause seizures and headaches, but I really don't expect them to ask you anything about these, but they are possible, I guess. HSV, meningitis, encephalitis. So this is the most common cause of encephalitis. So HSV. HSV1 is more common than 2 and affects the temporal lobe, or it's more likely to affect temporal lobe. So it's a preference for temporal lobe. It can cause personality changes, hallucinations, and aphasia. So it's more likely to cause problems with your parenchyma because it's an encephalitis. Diagnosed with PCR, treated with high-dose acyclovir. And so now we're looking at encephalitis. So this is inflammation of the brain itself. Again, has those fevers and headaches, but it doesn't really have that neck stiffness, or less so. It can still have them, but the altered mental state's a little bit more of a significant clinical feature. Again, like I said earlier, it's caused predominantly by viruses, can be caused by non-viral things, but predominantly the cause is a virus. Cool. So toxoplasma encephalitis is an intracellular parasite occur in HIV patients. It can cause abscesses and encephalitis. Yeah, these aren't too important. This is a disease, I guess, associated with HIV. Again, not critical, but it's entry of HIV into the CNS, which can cause these symptoms. Not particularly important, realistically speaking, but it's details. Zika virus is a flavivirus transmitted from the Aedes aegypti mosquito, causing encephalitis, microcephaly, and Guillain-Barré, but it's quite rare. This is some causes of acute encephalomyelitis. This is getting to the point of less important, to be honest, but this is direct causes, post-infectious causes, non-viral causes, and other causes. Have a look at this in your own time, but it's not overly critically important. All right, so brain abscesses. So these are focal intracerebral infections, and basically they start as an infection and then just the pus develops and capsule builds around it. You can get headaches, nausea and things, you can get focal neurological deficits. Predisposing things basically are infections that are near the brain, which can then spread, or trauma and things like that, or bacterial endocarditis, such as infective endocarditis, which causes emboli to seed into the brain, which might start a brain abscess. Most commonly it's from bacteria, but it can have other causes, and it's managed, or firstly imaged through contrast CT and MRI and blood cultures to literally see it, as well as then treated with surgery to drain it, as well as antibiotics and steroids to control it, basically. This is mold sinus infections, seen mostly in people who are immunosuppressed. People who are perfectly fine immunologically don't really get mold infections or fungal infections. Causes include aspergillus, which I think is the only one that's like really things even to like mention. The other two are just there. Again, treated with pharmacotherapy and may require surgery. And then I think this is finally actually, so subdural empyemas. So this is a collection between pus with dura mater and the arachnoid matter. If you remember empyemas in the lungs, it's basically the same thing, but it's in the subdural layer. It's of pus. Again, it's from infections spreading to that area. Symptoms include fever, headaches, impaired mental state, hand freezes, and seizures, caused by streptococcus, staphylococcus, things like that. These people do not need a lumbar puncture. Rather, they require decompressive surgery, as these people probably have an increased intracranial pressure, probably are at risk of things, as you can see with the midline shift, but I digress. And then finally, epidural abscess. So these have the classic signs of a fever, of infection, so fever, rigors, and then severe back pain, which is at the location of the problem. Radiculopathy just means problem or, I guess, pathology associated with that nerve. So because of that compression of that nerve, and you get motor and sensory deficits logically from compression. You need to MRI the whole spine because you don't know where specifically the lesion will be, or if there might be a couple of lesions, and these require surgery to decompress. And that concludes the presentation. So to those who are watching, thank you very much for watching all here. This marks, I guess, the conclusion for this year. If you have any questions, just feel free to message us on Facebook or things like that.
Thanks, guys.